All right, let's dive right in. In this explainer, we're going to break down the core principles of geriatric health maintenance. We're going to give you a framework that's designed to help you, as a medical trainee, provide the absolute best care for your older patients.
And why does this matter so much? Well, look at this number. By 2050, the number of adults over 60 is set to top 2 billion. This isn't some far-off future. It's the world you'll be practicing in. And it's not just a demographic shift. It's a complete change in the whole landscape of medicine.
This right here, this is the core belief that should drive everything we do. The goal isn't just about adding years to life, but really adding life to those years. It's all about preserving function and maximizing quality of life.
Okay, so here's our game plan. We'll start by understanding the modern context of aging. Then we'll totally rethink our clinical goals. After that, we'll get practical with evidence-based prevention, tackle the huge issue of malnutrition, and finally, bring it all together to see the whole patient.
First up, let's set the stage. Aging in the 21st century is a completely different ballgame than it was even a few generations ago. And that has some huge implications for how we practice medicine day to day.
Just look at this incredible leap. In just over a century, the average life expectancy at birth in the US has jumped by more than 30 years. That success has created a whole new set of challenges. How do we manage health over a much, much longer lifespan?
And you guessed it, with that longer lifespan comes a lot of complexity. The vast majority of your older patients will be navigating multiple chronic illnesses at the same time. You won't just be treating a single disease. You'll be managing these complex geriatric syndromes that are so strongly linked to a loss of independence.
So this brings us to a really critical shift in our thinking. We have to move beyond treating patients based on their date of birth. Our approach has to become more nuanced, more individualized, and maybe most importantly, focused on function.
This is a core tenet of geriatrics. If you have two 80-year-old patients, one might be out there running marathons while the other is frail and homebound. A one-size-fits-all age-based protocol, it just doesn't work. You have to remember, heterogeneity is the rule, not the exception.
Now, this brings us to a really fascinating and powerful concept called lag time to benefit. It's a tool that forces us to ask a critical question for every single preventative thing we do. How long will it take for this intervention to actually help my patient? And does that timeline even match up with their likely life expectancy? Let's make this real. Take colorectal cancer screening. Its lag time to benefit is about 10 years. So for a patient who you expect to live another 15 years, screening makes perfect sense. But for someone with, say, a 5-year life expectancy, the harms of the procedure probably outweigh any potential benefit. It's the exact same test, but leads to two very different and equally correct clinical decisions. So let's see how this concept helps us make practical, evidence-based decisions, especially when it comes to that really tough conversation about when it's time to stop cancer screening. Notice a key pattern here. For breast and prostate cancer, the recommendation isn't tied to a specific age, is it? It's tied directly to that 10-year life expectancy we just talked about. This is your evidence-based guide for starting those really crucial shared decision-making conversations. Now, in sharp contrast to all the nuance of cancer screening, immunizations are a cornerstone of prevention with clear, immediate benefits. These vaccines are a slam dunk. They're incredibly effective at preventing severe illness, hospitalization, and death in a population that's especially vulnerable.
Okay, let's pivot to a topic that is absolutely critical but often flies under the radar: nutrition. And listen, malnutrition isn't just about weight. It's a direct threat to your patient's function, their independence, and their overall ability to bounce back from, well, anything. Just look at how dramatically this risk increases as patients move through the healthcare system. It starts at around 6% for older folks living in the community, but then it jumps to nearly 40% for those who are hospitalized and skyrockets to over 50% in a rehab setting. This is a problem you will see every single day. So let's be really precise here. Malnutrition isn't just being thin. It's a specific clinical diagnosis that requires two things: a physical sign, like weight loss, and a cause, like not eating enough or having an underlying inflammatory disease. And it's also crucial to distinguish malnutrition from cachexia. Cachexia is an active metabolic process driven by inflammation from a disease like cancer or heart failure. The body is essentially breaking down its own muscle. This is not simple starvation.
And then there's sarcopenia, This is the age-related loss of muscle mass and, maybe more importantly, muscle function. It's a key driver of frailty and can happen even in patients who are overweight, which makes it super easy to miss if you're not looking for it.
So, how do you diagnose malnutrition when you're super busy? The GLIM criteria give us a really straightforward two-step framework. First, look for a physical sign. That's the phenotype. Then, identify a cause, the etiology. If you have at least one from each of those categories, you've got your diagnosis. Simple as that.
Now that we've looked at key areas like prevention and nutrition, let's zoom back out. Because really, effective geriatric care means integrating all of these assessments to see the whole patient. Think about this number for a second. 3 to 5. That's the average number of medications taken by adults over 65. Every single one of those is an intervention, and managing them effectively is one of the most high-impact things you can possibly do for your patients.
Your job isn't just to prescribe. It's to meticulously review and, maybe most importantly, to de-prescribe. Every single visit is a chance to ask, is this medication still necessary? Is it causing harm? Can we simplify things? This active management can prevent falls, confusion, and even hospitalizations.
And this brings us right back to our central theme. If you're ever unsure of what to do next, just ask yourself this: does this preserve function and maximize quality of life? Every test, every prescription, every conversation should be aimed at that one ultimate goal.
This leaves us with a final and pretty crucial question for the future. As our patients live longer and longer lives, often with a bunch of chronic conditions, the very definition of healthy aging is kind of up for grabs. The challenge for you, the next generation of clinicians, is to help answer that question, to move beyond just managing diseases and become true pioneers in helping people age well.